Hi everyone, my name is Shlomo Barkowski. I'm from Macquarie University, and I'll give this talk on health personalization, going from well-being to medicine. So this is the outline of the talk. Coming up, yep, this is the outline of the talk. I'll first introduce myself and motivate the work. Then we'll spend some time talking about clinician-centric personalization, what it is and how to achieve it. Then we'll talk about clinical decision support. And finally, we'll look deeper into personalization and see specific scenarios of personalization applied to healthcare and medicine. Now, I should say the talk is not technical, it's rather motivational talk, visionary talk, basically outlining where I see applications of recommendations and personalization in the health space. So I guess we can start now. So first I'll introduce myself. I worked for the CSIRO and NICTA, two research organizations, national research organizations in Australia. I'm coming from the personalization and recommenders background, and we had several activities on group recommendations and activity motivating games, and then TV recommendations. And then I jumped to the industry. I worked for Atlassian as the lead of their product analytics and data science team here in Sydney. And after a while, I basically, a bit under 2 years ago, I joined Macquarie University, where I'm leading a team working on precision health and personalized health. So even going back at my project at CSIRO, we had a large project called Tailored Lifestyle Information. That was a lot about, supporting people to maintain their lifestyle. It was about personalized meal plans and group recommendations of recipes, recommendations of physical activity, again, activity motivating games, personalized access to health information. So it was all about kind of helping people to maintain, to stay happy, to stay healthy, to maintain a healthy lifestyle. So all these kind of applications centered around users, around people. So when I started my role at Macquarie, I basically looked, okay, what's there in recommendations for medicine, recommendations for clinicians. So I looked at papers that were published at RecSys and actually other conferences as well. And there is a specific workshop at RecSys, which is called RecSys on health applications of recommenders. And I just put together this word cloud, just the titles. I removed obviously recommenders because that would have dominated heavily. So what you see here, you obviously see health, you obviously see personalized, but then there is support, healthy, well-being, shopping, food, recipe. You have medical at top right, which is kind of one word that was used. But again, most of the works here are works around lifestyle and well-being. Again, like food, shopping, exercising, workouts. So helping people to stay happy, to stay healthy. So it's all around those what we call consumers, around end users who receive those recommendations. And this was the kind of the dominant motive that I saw there. And on the contrary, there was nothing about, or pretty much nothing about recommendations for medicine, recommendations for healthcare. There were no recommendations of drugs, recommendations of treatment, no recommendations of diseases. So nothing essentially was facing clinicians. Most of the recommendations were facing consumers or just simple end users, which basically got me thinking, why is it the case? Why we don't see any clinician or hardly see clinician facing recommendations? So there are a few things that I think could explain. First, there is a lot of risk and responsibility here. If we have, say, a Netflix recommendation and the recommendation is not good, then the user will watch a movie that they don't like, they'll waste 2 hours of their time, but nothing critical will happen. If we have a bad recommendation of drug, for example, this may have very, very adverse effects. We could potentially kill a person, kill a patient. So that's obviously a lot of risk, a lot of responsibility. Now, even if we go if you do want to do recommendations for medicine and healthcare, there is no data, and there is no data not because people don't want to share it, but because there are lots of limitations around sharing data, around collecting personal data. It's obviously very personal, very sensitive data. So it's in most cases, clinicians just will not be able to share the data even if they want to. So if no data, obviously very hard to do machine learning, to do recommendations without data. But even so, if we stay away from statistical recommendations and go more towards content-based or knowledge-based recommendations, the life is not any easier, because again, unlike for example movies, medicine and health is a very complex domain with a lot of knowledge that is required to produce good recommendations. So bottom line, we need very, very strong domain expertise to do those things. There are some ontologies and knowledge representation models for medicine. There are quite a few of them, but still it's a very kind of knowledge intensive domain. So it's very hard to produce those recommendations. So I think kind of all in all, this is probably what we see with those risky domains that require a lot of knowledge, that there are no recommenders as such. And that's kind of why we don't see recommendations at nuclear plants, why we don't see recommendations for judges for court cases, why we don't see recommendations for VCs, venture capitalists, as to how to invest their money. So all those things, that's where basically the recommendations are too expensive, too risky. There is no data to produce those recommendations, and the recommendations do require very specific knowledge. So this basically brings one of the key questions that I wanted to ask in these presentations. Are recommendations for health and medicine, again for clinicians, not for end users, are they needed at all? So let's go and jump a little bit and talk about what those clinician-centric recommendations are. How do they look like? It's pretty much kind of a summary of my learnings in the last year or so, basically talking to clinicians, trying to understand the use case, trying to understand if there are chances to for them to use recommendations. So what does clinician centricity mean? What does it take to create clinician-centric recommendations? So first of all, something that's very important to bring up, clinicians are not just users, they're very, very highly knowledgeable users. So there are years and years of training and often years and years of practice. So they have experience. Usually they have an opinion. So when they see a patient and patient comes in and says, oh, I've got those symptoms, and the clinician will immediately have some idea as to what the disease may be. Obviously, it's not immediate decision. They may have 3, 4, 5 options, plausible options, something that could be that could cause this disease, but it's not endless space of opportunities. It's very limited space of opportunities, and once you have 3, 4, 5 options, you may not really need a recommender there, because you already have these ideas in your mind. And again, given the years of practice and the years of training, it will be pretty hard to surprise the clinician, right? It will be pretty hard to come up with something that they've never thought of. So they already have this opinion, and there are not too many options. They're very time-poor users, so they can potentially go back to the books, go back to the papers, and read and consult, but they don't have the time for this, because they have maybe 15 minutes to see this patient, including all the examinations, including the summaries and the paperwork, and they pretty much need to make a decision on the spot, or at least to make a reasonable hypothesis on the spot. So they don't have time to explore those alternatives. So even if there are some good recommendations to offer, I'm not sure they'll be willing to examine those recommendations. They're very risk-averse users. I've already mentioned this when I talked about what happens if the recommendation goes wrong. So they won't be keen to prescribe a new drug, or to come up with some really surprising diagnoses, because again, they're risk averse. If we're talking about movie recommendations and we're talking about serendipity and novelty as good characteristics, good features of recommendations in the movie space, here it's completely the opposite. They don't want, they in a sense opposed to novelty. They want to stick to the things they know. They want to stick to the things they've done, just because, as I said, they're risk averse and the errors are expensive. And moreover, I can even probably put it stronger and say that they are Luddite users. They really don't want these technologies. There is this fear that the technology will come and eventually replace them. I won't kind of go into whether this fear is based or not, but they're clearly protective of their role. They're clearly protective of their profession, and it comes through very clearly in discussions when you talk to doctors, when you talk to clinicians. This idea comes very, very often, and probably one comment to make here is that even if there is this recommender or this decision support, this AI that will help clinicians, it's not coming, it is a support tool. It's not coming to replace them, it's coming to support them. So if we are talking about new technology, a new support technology for clinicians, the comparison that will be done will not be clinician versus technology, it will be clinician supported by the technology versus just the clinician. So that's a very important distinction that I'd like to make. And now, if they are supported by the technology, then the value of trust that they place in this technology is very high, because essentially, if there is some advice or decision support that they're getting from the technology, then they need the whole idea of this support is that they take it up and then they use this device. So it's extremely, extremely important to build trust, so that the clinicians use this technology, take it up, and not just turn it off. And as part of trust, one of the key things, and it's really, really important, and I guess that's probably another big differentiator of recommendations or decision support for medicine, is explainability. And this is actually a verbatim quote by one of the doctors, where he said, like, no explanations, no value. So if there is just a decision support saying prescribe drug X, it's totally useless, because they need to be explained. They need to understand why the system suggests them to take this, to prescribe this drug X, because the patient has those symptoms, and he had this disease in the past, and he's allergic to whatever, to penicillin. So the recommendations of decision support, they absolutely have to be explained. There are various ways how to plug this explanation in. For example, for text, it can be some summarization or simply highlighting text. It can be highlighting parts of medical images that are relevant to the decision. If we are talking about high dimensional, say, genomic data, it may be highlighting the parts of the genomes, again, that explain this recommendation. But in general, this explanation is absolutely critical. As I said, no explanation, no value. And then the byproduct, something that comes with this, is the ability to visualize the data, and the ability for the clinicians to explore these data. So this interactive exploration is extremely important as well, which may come as a hard constraint to non-interpretable methods. In particular, once we are talking about deep learning, once we are talking neural nets, many of those methods, they are black box methods. So if we are using those methods, we need to pay special attention to the ability to explain. So almost like, okay, we have one module that will produce this recommendation, this decision support, and then we'll have another module that will produce the explanation, essentially why this drug X, why was it recommended. And then again, something that I already talked about, the errors are super expensive because we are talking here about life and death. The accuracy of these, the importance of the accuracy of this algorithm is paramount. It's just, it cannot go wrong. essentially, if it goes wrong, it will kill trust. The clinicians will not be, it may compromise safety of the patients. The clinicians will not be using those systems if they're not accurate. And we are talking here about really, really high levels of accuracy, like well into the 90%. That kind of the clinicians expect these systems to exhibit this level of accuracy well into the 90s. So the accuracy is important. And on this note, I wanted to talk a bit about the accuracy metric. So we are using movie recommendations. There is ranking accuracy, which is obviously inapplicable here because the list is not that long. We're talking about 3, 4, 5 alternatives, as I said before. So it's not about ranking accuracy. It's also not about predictive accuracy because there is no real score here, right? So it's not like 4 stars or 4.3 stars. It's not like this. So we are talking about classification accuracy. So we are talking about the decision support, the recommendations that are provided to the clinicians. They have to be relevant. So once we are in this space of classification accuracy, the usual things that, for example, again, in movie recommendations would be precision and recall. And then one metric that combines them is F1, for example, and for F1, we assign equal weights to the precision and to recall, which basically says, both of them are equally important. Now, let's look for a second on clinical recommendations. So the metric of clinical decision support. The metrics that are used to evaluate clinical AI are called sensitivity and specificity. So sensitivity is essentially the accuracy of the system for positive cases, for example, for people who have the disease. So the ability of the system to recognize that they have this disease. And specificity, that's the opposite. That's the ability of the system to accurately detect negatives. So essentially to accurately say, yeah, this person does not have the disease. Errors can go both ways. It can be false positive, it can be false negatives. So if we have a false positive, essentially the person does not have a disease and the system will suggest that the person does have a disease. That's a specificity. So the person will receive treatment that they don't need, which is obviously not good, right? It's what we call overdiagnosis. The person does not need to receive a treatment. The person does receive a treatment. Some treatment can have pretty harmful side effects. But this is probably nowhere near the opposite condition where somebody has a disease. Imagine somebody has a cancer and the system says, no, this person is good. The person goes home, does not receive any treatment. Obviously, the consequences can be really, really horrible. This is underdiagnosis. This is an error in specificity. The specificity will go down. As you could have probably guessed from kind of this intuitive example, it's not the same. Overdiagnosis is not underdiagnosis in terms of the implications and consequences of this. So we cannot go with something like F1 just because they're not balanced. They're not the same. One type of errors is much more expensive than the other. And of course, as I said at the very beginning, like both types of errors are pretty bad because of the impact on trust and so on. So back to this question that I asked, and probably you could guess by now what my opinion is here. Are recommendations needed? I would argue that the recommendations as such, as in the scenario that we are used to, like recommended systems for e-commerce, for movies, probably there is no real use case for recommenders in health and medicine. And I've got here two like very strong, very well cited papers and recommended systems. So this is Resnick and Varian, mid-90s. Look at the very first sentence. It's often necessary to make choices without sufficient personal experience of alternatives. This doesn't work for clinicians. They have a lot of personal experience. They have a lot of personal knowledge. Kind of, we break it at the very first sentence. And the other example is Francesco Ricci and co-authors RecSys handbook. I think that's the second edition, screenshot from the second edition. So again, the highlighting is mine. First sentence, recommended systems are software tools and techniques that provide suggestions for items that are most likely of interest to a particular user. That's sort of right. So we have those recommendations for clinicians, but then look one paragraph below, recommended systems are primarily directed towards individuals who lack the sufficient personal experience or competence, right? That's not the case. That's just wrong again for clinicians. In order to evaluate, I continue reading, in order to evaluate potentially overwhelming number of alternative items. Again, that's not exactly right, because as I said, they have several plausible ideas, and the number of conditions that could be there is like 3, 4, 5. It's a very small number, definitely not an overwhelming number of alternative items. So I'd argue that we don't have here a use case for recommendations. What we do have here is a use case, a strong use case for decision support. So we have this second opinion, if you wish, where we have the clinician, the doctor, human doctor, who makes the decisions. And we have the second opinion by the technology that can express yet another opinion. So kind of junior doctor, junior decision support to the clinician who makes the decisions. It should be something important, and it's really important to call out that the decision support is personalized, because if there are two different patients, and we'll talk in a second about this difference, how this difference may be expressed, but if there are two different patients, they are likely to get different drugs, maybe different diagnoses. So it's not one size fits all. It is personalized decision support, because there'll be different suggestions in different cases. Important and really important to highlight, the personalization is not it's not personalized to the clinician. It is personalized to the case. So same clinician will get two different recommendations for two different patients. So what are those patients? What are those user models? In the user model in terminology, we have the symptoms, like the person is complaining about something, the patient is complaining about something. There may be examinations or blood tests. The person may currently have another disease that may affect the current symptoms. The person might have had previous diseases that affect their current condition and affect their current symptoms. So all those things, and there are many more, because with pathology and blood tests, you can go really deep and you can examine various things. But all those things, this is kind of the user model. This is what affects the personalization. So again, I would argue we're talking about clinical decision support rather than clinical recommendations. And I'll go a little bit pretty quickly, because we don't have much time. I'll go over the ways where the personalized decision support can be plugged in. And I'll speak maybe 30 seconds about several of our projects where we are doing this. So first, a few words about clinical processes in general, how they look like. There are three big components, three kind of stepping stones in the clinical process. First is diagnostics. Diagnostics is about identifying the disease or condition of the patient. So the patient steps in and he complains about something, and the doctor needs to diagnose, to identify the reason, the disease, the cause of those complaints and symptoms. Once this is identified, we have two things. First is prognostics. So these symptoms look bad. Maybe it will take the person 2 weeks to recover, or the symptoms are very mild and it will take 3 days to recover. This is the left-hand side, essentially predict the disease progression, predict where the disease is going. And the other component, which you see on the right, bottom right, is therapeutics, is essentially the drugs or the treatment. So we have the diagnostics. We know that this person has COVID-19. How do we treat this person? Do we give them Panadol and send them home, or do we need to hospitalize this person? So essentially, what's the appropriate treatment given this condition? What's important to call out again, that these two things are very strongly dependent. So it's not just once we have the diagnosis, prognostics and therapeutics go hand in hand, because if we give an aggressive treatment, for example, the prognosis may be better. Maybe it will not take 2 weeks. Maybe it will take a week, just because we are giving more aggressive treatment, and it can go vice versa. We we can change the therapeutics depending on the prognosis. So somebody who is 30 and has COVID-19, the treatment will be different from somebody who is 90 and has the same COVID-19, maybe with the same symptoms. So these two things are really go hand in hand, and very often treatment changes as a function of the prognosis, and the prognosis changes as a function of treatment. So in this space, we, if we look kind of, I'll try to formalize the problem again. It won't be very tight. Formalization will be mainly hand waving, but if we look at the top block of diagnostics, we can think of diagnosis, which is the outcome or the decision support in this case, as a function of that user model that I talked about. So it can be the demographics of the patient, their past medical history, their current symptoms, their examinations, blood test and pathology, other conditions that they have, and so on and so forth. So all those things go together, and the clinician needs to make a decision. What is the diagnosis? So what is the reason? What is the disease that causes all those things? So I'll go through a few projects that we are doing, probably 30 seconds for each. So the first one is in the mental health space, where we have online screening tool with lots and lots and lots of questions filled out by parents of kids that may have anxiety disorders, that may have a mental condition. And essentially, we have ground truths of those kids that were examined by clinical psychologists. And we are trying to associate the answers of non-professionals, the answers of parents, and try to develop, we trained actually machine learning to predict those anxiety disorders from the answers of the patients, where the ground truth is the diagnosis of the clinical psychologist. Another thing which is obviously very hot these days, very important these days, is the screening of COVID-19 using sensors in standard smartphones. Again, it's not really diagnostics, it's more of a screening tool, because the diagnostic is still something that requires a PCR, but we are using acoustic signal, that what you see on the left, and vital signs captured with the camera, that what you see on the right, to train machine learning, essentially to detect COVID cough from a non-COVID cough. This is the acoustics, and the vital signs are more into blood oxygenation levels and pulse. We're using those vital signs to predict if a person has COVID or not. Another one which is much more interesting to my taste is the ability, or the question of predicting neurological, well, it's not neurological, in this case it's in the mental space, ADHD, attention and hyperactivity disorder, I think. I've got the second D, the first D, using EEG signals, so essentially using brain activity to predict attention deficit and hyperactivity disorders, that's the right name, in kids, using EEG and brainstem responses. So those tiny electric signals produced by the brain, using them to predict ADHD of kids. And another thing which goes heavily into image processing is essentially the ability to differentiate brain tumor from radiation necrosis in MRI images. Essentially, both of them look very similar, but one of them is a byproduct of treatment, whereas another one is a recurrence of the tumor. So this is in the diagnostic space. And then we go to the bottom two, which probably received so far reasonably little attention in our team. One is prognostics, where we look at the diagnosis and the treatment to predict the progression of the disease. So the first would be a small project that we've had with chest CTs of diagnosed COVID patients to try and predict how COVID-19 will progress. Like, essentially, will this person require lung ventilation? Will they need to be hospitalized, or their condition is mild and they'll be fine So we've developed image-based technology to recognize these in lung CTs, and there is some sort of feature importance plot on the right. And the last bit is essentially therapeutics, where we have the diagnosis, we have the prognosis, we have the progression of the disease, and we are trying to predict what's the right treatment or what's the right drug. So what we have here, we have a project where we're working with the Melanoma Institute Australia. We are analyzing genomic data of melanoma patients, trying to predict if they'll respond to a drug. So just to sum it up, there is a space here to application of AI and more specifically RecSys methods, but and many methods can be applied. I should say hard to apply methods off the shelf. They need to be adjusted, they need to be tuned, and we're talking about personalized decision support tailored to patients. But the decision is still made by a clinical decision maker. And we talked about all these constraints about data sharing, about safety, about explainability. We talked about those things. And finally, the last part of the presentation, where does personalization, more specifically, not just AI, but personalization, where does it fit? So I split this into 4 different slides. The first one is about user modeling. Essentially, what do we do with this data? There is a lot of data, a lot of coming from wearables, coming from various pathologies and blood tests and examination and so on and so forth. How to deal with this data, how to select the right data, for example, for a case of genomic data where we have, for example, this project was Melanoma Institute Australia. We have genomic data of about 25,000 genes, and every sequencing is extremely important. So we have about 200 patients. So if you look at these metrics of 25,000 by 200, it's very hard to do machine learning with this sort of data. The second group of challenges in this is in the space of algorithms and methods. So how to tune those existing AI methods, how to perfect top 1 decision support. That's probably the million-dollar question, because it's a very small number of options, maybe not top 1, but top 3, but how to perfect these top 3 decision support. How to harness contextual data, and I put contextual in kind of inverted commas, because it could be clinical context as other morbidities or past morbidities, or it could be lifestyle, which is the environment. Then there is the interaction side, where the questions, how to incorporate explainability. Explainability is extremely important, in particular when we are talking about neural methods, how to make sure that they are explainable, because it's absolutely critical for trust. And finally, another practical implication, but it's very important, it's security and privacy. We're talking about very sensitive data. Even when we aggregate it, when we do it, how do we make sure that the data doesn't leak, that the system cannot be attacked? So how can we have this privacy enhanced AI, be it encryption, be it on-device computations, but the question is still there. And finally, I think that's the last slide of the presentation, kind of my 3 subjective, high-risk, high-return picks. Number 1, knowledge discovery in high-dimensional omics data. Be it proteomics, be it genomics, we have those vectors of something like 20-25,000 features. Each data point is very, very hard to get. How can we do machine learning with this sort of data? Item number 2, diagnostics and prognostics of neurological conditions. That's back to EEG and the ability to capture brain signals, electric brain signals. How do these brain signals, how do they correspond to the development of neurological conditions and the progression of these conditions? Can we do some machine learning of those signals, of this temporal data, and predict something? And the last bit is obviously going from AI to usable AI, going to AI that clinicians will be using. It's hard. I mean, there is a lot of research, a lot of efforts into AI these days, and essentially the question is how to make them, with all the things that come out of this, how to make it practical and usable by real clinicians, by doctors. So I think here we'll stop. We are pretty much finishing. We're running out of time. So again, I unfortunately couldn't be there in person and present. The time difference is horrible, but I would absolutely love to receive feedback on this presentation. You've got my email, firstname.lastname@macquarie.edu.au. Please reach out to me. Please contact me. I'm open to collaborations. So if anything here sounded interesting, if you would like to discuss anything, please reach out to me and I'll be happy to talk. Thank you very much. And I will stop the recording. Thank you. Bye.